Well, thank you everyone for coming and welcome to today's webinar, Rural Health, a Guide for Digital Health Transformation. My name is Natalie Daniel. I'm the Unite Us Policy Director. I'm thrilled to be guiding this conversation on rural health and how technology can support rural communities. Today, we'll be discussing the current state and future state of rural health transformation, particularly how technology can contribute to that transformation. We will be discussing the innovative Missouri Medicaid, Missouri Health Net's transformation of rural community hospitals model, or ToRCH model. We will also touch on the Rural Health Transformation Fund, part of the historic H.R. 1 legislation, which provides $50 billion to strengthen rural health systems nationwide. With applications for the Rural Health Transformation Fund due at the beginning of November, states and rural health leaders are now in the early planning stages. Today's discussion is to help you think creatively, and position your state for success. I want to note who we're joined by today. So we're fortunate to be joined by Missouri's own Justin Clutter, PMP. He's the Transformation Office Project Manager at Missouri's Department of Social Services. He's really overseeing the ToRCH model. He brings both real-world experience and innovative thinking around rural health transformation. I've been greatly enjoying working with Justin for the last few years. Accompanying Justin is Kelsey Hague, Unite Us's account executive, who is our resident expert on all things ToRCH. Kelsey is brilliant and will be a great addition to really help us explore the technology side of the ToRCH model. So thank you both for speaking today. During this session, we'll explore what makes rural health unique, lessons learned from the ToRCH model, and opportunities to leverage technology, data, and partnerships for sustainable impact in rural communities. We also want this to be interactive, so please submit your questions in the chat or the Q&A. There's a Q&A box, I think it's on the right side of your screen, and we'll make time to address those at the end. So let's dive in a little bit to talk about rural health. As I mentioned, the Rural Health Transformation Fund, or RHTF, is a historic investment into rural communities. This fund was authorized by Congress through the Reconciliation Bill, H.R. 1, that was passed at the beginning of July. This bill is also known as the Big Beautiful Bill, for those who are familiar with that. What is in the bill is most of what we know so far about the fund, and since this is the first of its kind, we're all sort of learning as we go. What we do know is that there's a large focus on technology, prevention, innovation, and sustainability in its authorized uses. These focuses tell us that this fund will be used to kickstart lasting and transformative change in rural communities. Rural communities are strong and resilient. I don't want to underestimate that. They have to be. When it's only you or your family for miles, you need to be self-sufficient. We respect and understand rural communities' strength and everything that they do. Unfortunately, sometimes, by virtue of being rural, this can also mean that there are fewer hospitals, shortages of healthcare providers, and longer travel times for basic care. Many of these rural health service systems have been cut or consolidated, leading to less access for rural community members. In addition, we also know that rural residents often experience higher rates of chronic conditions, such as diabetes, heart disease, substance use disorder, but have fewer resources to manage them. We see these concerns, which are only a tip of the iceberg, as an opportunity to support integrating technology and innovative care models to support better access to care, right-sizing rural health, and improving outcomes. This aligns closely with the goals of the Rural Health Transformation Fund. The intended uses of the Rural Health Transformation Fund is to align closely with the following strategic goals, which is demonstrated through the approved uses of the fund as outlined in H.R. 1. The first one is make rural America healthy again by supporting rural health innovation and new access points to promote preventable health and address root causes of disease. Sustainable access by helping rural providers become long-term access points for care by improving efficiency and sustainability. Workforce development by attracting and retaining a highly skilled healthcare workforce by strengthening recruitment and retention of healthcare providers in rural communities. Innovative care by sparking the growth of innovative care models to improve health outcomes, coordinate care, and promote flexibility care arrangements. And finally, tech innovations by fostering the use of innovative technologies to promote efficient care delivery, data security, and access to digital health by rural facilities, providers, and patients. You'll see in our discussion today how the ToRCH model really reflects almost every single one of these priorities. Oh, I went too far. Sorry about that. We are seeing many states right now collect information and feedbacks on their approach to the Rural Health Transformation Fund ahead of applications. We know that this is the timeline that we've seen so far. So this is what CMS has shared. We hear that the applications will be coming out mid-September. To me, that's next week. So we'll be keeping a close eye on that. There's a quick turnaround on the applications, with them being due at the beginning of November and approval and reviewed by the end of the year. Then funds will begin flowing in early January. With no time to waste, I want to get into our discussion with Justin and Kelsey to share an innovative model of care that directly supports rural Missouri communities. This type of model closely aligns with the goals and approved uses of the Rural Health Transformation Fund and provides sustainable solutions to support rural communities. Moreover than that, I think that the Missouri Health Net is doing really amazing things for Missouri and Missouri rural communities. And I really want to highlight that and show how great that work is. So I'm going to pass the torch, if you will, and start asking questions of Kelsey and Justin. Here's just a couple statistics about the ToRCH model, but I'm also going to have them start with really sharing how, and this is a question first for Justin, how the Missouri Health Net's transformation of rural community hospitals, or ToRCH model concept was developed, what problem it intends to solve, really just describing what the ToRCH model is. And I'm going to share this infographic for that conversation, and then I think I'll stop sharing the slides for a little bit. But Justin, could you talk to us a little bit about how this was developed and problems it intends to solve?
Yeah, thanks, Natalie, and thanks for joining today to hear a little bit about what we have going on in Missouri here. The transformation of rural community health program was kind of born out of the idea that I think many rural states struggle with, and how do you sustain healthcare in rural communities? You see so many struggle, not only financially, but just getting some meaningful patient population to come through their doors. A lot of the participants, specifically in Medicaid, they'll drive right past their rural hospital to go to a larger, more urban facility. So we really wanted to think about rural healthcare differently. First, how can we keep those pockets of people healthy and keep them from going and traveling farther distance to get their care, to really bring them back, get their care within their community, and build some kind of sustainability for that facility. You see a lot of the times, and we're very open and honest with our rural hospitals and urban hospitals, that they think about healthcare as more of sick care rather than health care. When you look at your financials and you're struggling, the first thing you want to do is get more sick people in the doors so you can help your revenue margins. And we want to think about this differently, where we can look a little bit upstream to try and figure out what those social drivers are that are causing these poor health outcomes. Things like food, transportation, housing, something as simple as a handrail can keep an elderly person from constantly coming to the ED to receive their services. And you see in the infographic here, if we have a one pager to try and explain ToRCH, this is kind of what we do. And it's born out of this idea where we want the community to tell us what they need to make this happen. It's very much a very trusting relationship. We're putting a ton of trust into the community, and they're working with the state government like they never have before. So we asked them, and we have 6 rural hospitals that are participating in this pilot, to form a leadership board. And you can see in the graphic what makes up that leadership board. It's your hospital, your primary care or clinical providers, and community-based organizations like your food banks, those individuals providing that transportation service of some kind. and we're kind of infusing them with some upfront dollars, things that they need to stand this up. So if they need dedicated employees or staffing to lead this effort, we provide that upfront funding. We also provide capacity building funds for any community-based organizations. So if you have a food bank that maybe just operates in the basement of a church on a Tuesday night, and they can't possibly take this influx of Medicaid participants, so we give them an opportunity to apply for some funding to expand that. Maybe they need some hired staff to work it, or maybe they just need a computer to work with the Unite Us platform to receive referrals. There's a lot of things like that happening. One in particular that we love to rave about is in one community, they stood up a single location to have 10 different social agencies located in one spot. So it's a one-stop shop happening there, and they only take walk-ins. You don't need a reservation or an appointment. As you show up, they help you in any way that they can. Whether it's you just need a shower and you're homeless, or you need to do your laundry, those are the things that they help them provide. They'll help them find a job. They will help them with financial assistance if they just need some guidance there. They'll allow you to use their office as a mailing address. So there's a lot of different creative ideas coming from this collaborative effort. You'll see that there are some incentives to improve population health goals. All of our sites have population health goals that are specific to their community. Those aren't necessarily coming down from the state perspective. We're asking them to formulate what you want to do and what will make the biggest impact on your community, and giving them the freedom to select those themselves. There's some obvious oversight. We want to help them ensure that they have good data resources to monitor them along the way, and set some baselines and goals that will help them with. The other piece here is to reduce the Medicaid hospital spend. So we're ultimately looking to keep people out of the ER, reduce all-cause hospitalizations, things of that nature. And that in turn creates this shared savings model where if they do reduce the spend in the Medicaid space in their facility, they can earn up to 75% of those funds as a shared savings. So we loop those dollars back to them to sustain the model over time. And in a mature model, we're envisioning year 5 really is where that shared savings starts to flow through. And the operating funds that we've fed into them upfront reduce and are replaced by that shared savings total. And down the right side here, you can just kind of see that the ToRCH model, kind of the hospital is kind of your main hub. They're responsible for the model. They're responsible for administering the funds. They're working with the CBOs and can earn that net benefit from a mature model. Where primary care comes in, they are doing the screenings for, SDOH is kind of a bad word right now, but they're doing those screenings up front. We are paying for those screenings, so there is an incentive to get as many clinical providers doing those screenings, and they're making those referrals and working with those individuals to make sure that if they're getting that medically tailored meal, that it's helping them in the long run to improve their health care. The other layer here is the community-based organizations. They are really boots on the ground with how this all works. They're seeing these individuals day in and day out, working with them. They're receiving these referrals. They're using the Unite Us platform to get those referrals. And we also have the payments piece in Unite Us where they can actually get paid for B3 services. And by B3 services, the mechanism in which we got CMS approval to stand this up, a lot of states are using 1115 waivers. We did it a little different and used our 1915B waiver to provide B3 services. And those do include medically tailored meals, transportation that happens outside of our normal NEMT benefit. And we are also paying for home modifications like pest control, handrails, handicap ramps. So there's incentive on those community-based organizations to receive funding for providing those services. And you're gonna, the hope here is that years 1 and 4, we're providing that upfront investment, making the model really mature. And by year 5, there is a sustainability plan in place that can help them continue this on into the future. Like I said from the start, there are 6 hospitals participating right now. Missouri has 52 total rural hospitals. And we think there's a huge amount of buzz around this. We've talked about it in many different spaces. Some other states have contacted us about how we did this, particularly through the 1915B waiver. We're really excited about it. Happy to, talk more about it as we go along. But that's basically the gist of how we stood it up and how it's working today.
That's awesome. Thank you, Justin. Really great comprehensive overview of that. I want to just check with something with you, Justin. This infographic with this information on it, that's available on the Missouri Health Net's website, right?
I believe so. If it's not, we'll throw it out there so everyone has.
I think it's just helpful to have this for people to know. I'm going to stop sharing this, but Kelsey, could you maybe cover to bounce off of what Justin had said from a technologies perspective, how Unitas supports the model? Justin covered it a little bit, and then describe the implementation, the technology implementation of ToRCH.
Yeah, sure. I'm happy to kind of jump in from the technology perspective. So, as Justin kind of said at the very beginning, and as I've been thinking about all of this, I think one of the key factors of this whole project from the very beginning, and Mo HealthNet really set the stage, has been trust. So building trust within these rural communities, especially as a technology vendor coming in and letting the hubs themselves really lead and guide the implementation, because at the end of the day, they know their communities, they know their unique workflows and needs, and so really following their lead on that. And I think Mo HealthNet has done a really good job of leading that mindset throughout this whole project from the beginning. But really, starting in 2024, in January, we have been in implementation mode. And while the actual implementation of the technology, that piece really has not taken very long. Unitas is a fairly easy to implement product with a quick timeline. But the whole implementation really started with getting to know the individual hubs and the hospitals there that were leading the implementation. So getting to know their leadership, but then from there, helping to identify and that visual that Justin walked through, it's not just the hospital that we're implementing at. It's all of the primary care facilities, it's the FQHCs, the health departments, and then all of the community organizations as well. So having a lot of strategic conversations around, who are their priority partners in their community, having large meetings where we've gone on site in person, come together. Mo HealthNet was there, the hospital was there, and then all their community partners along with Unitas to talk about what this is, and having those in-person collaborations, I think were really, really critical in this implementation phase. But from the 2024, to where we're at now, all 6 hubs are completely onboarded. Their key partners are onboarded. We continue to always identify and bring on more, especially as Justin said, this a lot of buzz around ToRCH, and additional community members are, seeing the value that it's bringing to their communities, and they're also coming on board. So that work really never ends, nor do we want it to. As well as from a technology standpoint too, is not just the core platform of Unitas, which really helps coordinate and connect, healthcare and social care through our closed loop referral platform. But we have our billing product called Payments, which allows for that, invoicing, reimbursements, and authorization workflows that they can do with the ToRCH B3 services that Justin mentioned. So having those funded programs, being able to invoice for those programs from a social care perspective. So that was a big piece of the implementation, along with integrations. So knowing that we kind of have to meet our the hubs where they're at in terms of their workflows. So a couple of the hubs had EHRs that we were able to integrate with right away. So an Epic implementation over in Phelps County was able to allow for a broader range of their staff to access Unite Us, pull over the patient information directly into Unite Us to make those referrals. I think a great thing with this project is that MoHealthNet said, if there are barriers for integrations, like let us help, let this model and everything help kind of bridge that gap. And we were able to do the first ever Meditech integration with Citizens Memorial, which was one of the ToRCH hubs through this project. So we now have a Meditech integration, and we're actually getting ready to do 2 more implementations at 2 other sites as well. So ongoing work for the implementation. Let me see here. Yeah, and really now just kind of focusing heavily on adoption across the hubs.
Awesome. Thank you so much, Kelsey. I want to keep moving with questions, but I wanted to make sure, always feel free, Justin or Kelsey, to jump in as we're asking questions. If there's something you want to add, don't want to be shy here. I think you all started touching on this, but to put a finer point of it, Justin would love to hear, how's it going? We talked about the concept and where it's at, and we talked a little bit of how it's going, but what lessons have you learned? How's the ToRCH model going? Give us a little guidance on what we've learned and how it's progressing.
Yeah, I think it's going great. I mean, the 6 sites that we have really dug into this. Like I mentioned before, this is a completely different way of working with a state Medicaid agency. And I think that was a little bit of a hurdle to get over with. Like, you have a state agency coming in and we want to give you all of this power to make these really hard decisions. And they're not used to that. We weren't used to it. So building that trust took a little bit of time, but we got through it. One of the biggest wins that I think we have seen is just the ability of this program to get all of these partners in the same room and talking about, improving the healthcare of their community. A lot of the times you have a hospital working over here, an FQHC working over here, a behavioral health specialist doing their own thing here, your local public health agency doing something else. They're all siloed. And getting them in the same room to speak about something like this, and them learning, oh, I didn't know you did that. We were really struggling in that department, and we can work together to solve this thing. That has been a huge win for this program. It's opened up so many doors. There's so many new friendships made through it. A lot of good collaboration, and we have 6 sites, but you can't go into this thinking that every rural community is the same. I mean, you've seen one rural community, you've seen one rural community. They're all different. They all have different capacity, even within their sector. You might have a critical access hospital where the person you're having run the ToRCH pilot has 5 different other job duties that are completely separate from ToRCH. So it's harder in some of these spots. So working through those different things has been, a learning process for us and the participating hospitals. But it's been very rewarding. We're seeing a huge uptick in referrals. The payments pieces are really starting to flow now. They're getting a lot better at problem solving as something completely out of left field comes through and can ToRCH take care of this? And they pitch it to us, and we're like, well, let's think about this. It is a collaboration of a lot of problem solving to make sure that we're making the best out of the project. One of the things that has been hard is that ToRCH doesn't have the capability to solve everything that's happening in a rural community. We can't go about building new houses. We know everybody's struggling with houses. It's just something that Medicaid cannot pay for, and we can't create this big booming workforce. We can do bits and pieces of it, but there are things that we just can't solve, and those have been some hard conversations. But the unique thing with partnering with Unite Us is that we have the ability to get those infrastructures in there. So even though it's not a ToRCH specific referral, we can get them referred to a job force grant project that we have that's state funded. They still have an avenue to send these people to. And I think that's been a really rewarding piece of it.
Yeah, that's an awesome point. I don't know, Kelsey, if you have anything you want to add there, but I did want to follow up, Justin, and ask you. You spoke a little bit about the friendships that have been made, and maybe we can talk more about best practices for building these multi-sector partnerships and those friendships to create lasting rural health improvements. Maybe Justin, you can comment on that, and then Kelsey, if you have anything to add around really how the technology and how Unite Us tools can support those relationships, that would be great. But yeah, how are those? What are the best practices around building those friendships and those relationships?
Yeah, I think we've all gotten used to the virtual aspect of the way we work today. COVID sent us all home, so we're used to talking to people through a computer, but we've made a dedicated effort to go on site to all of these places. We want to see their facility. We want to know, hey, is your roof leaking? Like, we want to put eyes on what's going on there. We want to meet the people that are on the ground doing this work. We've met people that, have tried to do their own version of Unite Us just through a Rolodex. Like, Betty down the hallway knows everybody in the area and just has their number written on there. Like, we want to fix things like that and make sure that they understand that we're dedicated to being hand in hand with you through this. But that face-to-face interaction has been so important here. Kelsey mentioned that we do go on site. We rotate throughout our sites every quarter, and we spend the entire day there just brainstorming. We'll have dedicated topics to work through. There's a lot of lessons learned there, and it gives the opportunity to all 6 hospitals to meet their cohorts, the person doing their same job, but 4 hours away. You build that camaraderie, and everybody wants to see this successful, and that's been probably one of the biggest things. We're there face to face, sitting in their hospital, learning about what they're doing, and I think that's been really cool.
Kelsey, have anything you want to add there? Anything from the technology perspective of building those relationships?
Yeah, I think one of the biggest things I've seen as part of this model is just like the governance structure and the importance of it. And I think something that I really have enjoyed is that it's at all levels, right? So there's like a community leadership board where it brings together, the hospital leads it, but they bring together all of their community partners. And then there's a ToRCH advisory board at each of the hospitals where kind of that leadership meets. And then that's kind of what Justin was talking about. Those groups come together quarterly in person. And then there's even a state advisory board level where, we kind of rotate through the key stakeholders that are a part of that to kind of brainstorm at a bigger level. And I think, from a Unite Us perspective, being able to build relationships at each of those different levels has been extremely critical in terms of being able to always kind of point back to the why. Why are we doing this? Because anytime you're implementing something new in terms of technology, there's a change management component that occurs. But having, everyone at all different levels have buy-in along the way has really helped us keep moving forward and keep everyone aligned with the importance of some of this new implementation and new adoption.
Yeah, absolutely. Yeah, that's really helpful. Thank you, Kelsey. To refine that a little bit and to expand beyond just ToRCH, would love, Justin, if we can talk about how other states and Missouri and other states can harness technology and data infrastructure to improve care coordination, track outcomes, and even maximize the impact of the Rural Health Transformation Fund funding or other funding models. if you could talk through that a little bit, and then Kelsey, I might ask you to see if you have anything to add there.
Yeah, that might be the hardest question. I think we're all 50 states are kind of still waiting for the notice of federal opportunity to drop. I think we're all hitting refresh on their website for that to come out at any minute. We do view the ToRCH model as kind of being the chassis in which we can build out our application on. We have this infrastructure. We've been working to build this for 3 years. This whole hub and spoke model is really how we envision, rural healthcare prospering in Missouri. It's a unique opportunity, maybe a once in a lifetime opportunity to get this funding through the federal government. And we are leveraging a lot of our stakeholder groups, different state departments, different associations throughout the state, because we want to make sure that we have their input on however we structure our application for that funding. The one unique thing that we have done through ToRCH is that we have built some partnerships with we have a Missouri Hospital Association. They are basically a stakeholder group with a large membership of hospitals within Missouri, both urban and rural, and have a ton of different data analytics capabilities that the state government doesn't. So we've been able to leverage a lot of that with them and can see, in this specific rural community, obesity is really a problem, or hypertension is really a problem over here. SUD is a problem over here. So we can kind of pinpoint, what's happening in these rural communities already. And obviously taking it into account, what the community feels their greatest needs are is important too there. But we've dashboarded all of this, have it readily available through our ToRCH pilot. So we'll probably leverage a lot of that with our application. We're leveraging the relationships we have with our managed care organizations through ToRCH that we can hopefully continue to leverage with our additional funding. But things like HEDIS measures in a specific county, a local rural hospital may not know that data exists and they're able to get to it. So our managed care organizations have really helped, pinpoint our well child visits going good in this area, our kids getting dental visits. So those are things that we've been able to loop back to these hospitals so that they can see, like, I'm better than I was last year. So it's like this, morale booster when they can see that these things are making a difference. So I think those are kind of the data pieces that we've been using through ToRCH that I think will help formulate our application for the rural health transformation funding.
Yeah, and do you see maybe other states being able to learn these lessons? Someone asked in the chat if this is just for Missouri, and I want to note that the Missouri ToRCH model is just for Missouri, but the Rural Health Transformation Fund application is for all 50 states, and we really see what Missouri is doing as something that others can look to a bit as well. Do you feel the same way, Justin? Is that something you think other states can look to learn lessons learned as you guys are going?
Yeah, absolutely. I mean, we've kind of look at ourselves if we've made a lot of the mistakes that some states haven't, and can probably formulate a pretty good, outline for how this can be done. And around data, yeah, I think all states probably have access to the same type of data. It's all in a matter of how you formulate, your thoughts around what the data is telling you.
Kelsey, is there anything you want to add there about how states can harness technology and data infrastructure to improve care coordination, track outcomes, and maximize the impact of different funding sources?
Yeah, I mean, I think Justin hit on a lot of good points. I mean, it's one of those things where there's lots of different avenues to get data, but it's just kind of, how can you use data to support the thing you're going after, right? And so there's lots of different data to access. I think from a Unite Us perspective, what I think is, Unite Us yes, it's a tool and a technology to help with care coordination. We know in these rural communities, in all communities, that care coordination has been happening outside of Unite Us and without Unite Us for a very long time. However, what Unite Us allows is just that visibility into that coordination. And that really comes with the data. And so being able to see, and this is kind of something, we meet regularly on with all the hubs, and the conversations that we have is, looking at the data to see, are the referrals we're making, are the connections that we're making to care, are the individuals getting the care that they need? So instead of just, hoping that someone goes out and gets connected to care, now we kind of have that visibility to close the loop, and then using those insights to inform our strategies. So knowing, from all the way from the top of the funnel down to the bottom of, identifying the needs of the community members, to what resources are actually available, to are they actually able to serve this individual, really helps from like a ToRCH model perspective design. Do we need to use funding, or do we need to strategize around bringing on more resources, or is it more about helping individual resources have more capacity to serve? So really the data and the insights are really critical when it comes to informing the strategy, especially for ToRCH, but also for larger statewide strategy as well. I think the last thing I'll just say real quick is, from a Unite Us product standpoint, obviously we have our data outcomes like that I've just talked about, but also looking at things more predictive. We have, different products that help with those predictive analytics to really look at your populations and understand their needs. And so it's a very vast database of data that Unite Us has been able to pull together to say, in this particular county, we can see these are the top service needs. And this type of insight allows you to be more strategic when you're coming up with these types of plans.
Yeah, absolutely. I want to jump into some questions that we've gotten in the chat. But the first one is kind of a play on a question that I had prepared and in the chat, which is, how was ToRCH, and this is for Justin, how is ToRCH designed with sustainability in mind? And what lessons can other models take from this approach? So really trying to understand the sustainability of ToRCH. And then Kelsey would welcome any thoughts that you might have there as well.
Yeah, I think what we wanted to stand up was we didn't just want to flood rural Missouri with a bunch of money and it just dries up, and we're continuing to see the same things in rural communities. We wanted to build a model that we could provide some upfront investment in, but ultimately sustains itself through a shared savings process. We're looking to save money on the Medicaid program when it comes to hospitalizations, but that can be scary to a rural hospital that relies on that funding. It's scary to think, oh, the state wants us to reduce services. Well, then we don't have all of this money. That's not what ToRCH does. Yes, we want to reduce services, but that savings is going to come right back to you at a potential 75% match, depending on how you do on those measures. So the better you do on those measures, the more you can reduce hospitalizations, the more you can reduce ER utilization, the more you can reduce the population health goals that you have selected yourself, the more of that shared savings you are able to reward yourself with. So it wasn't designed to just flood a bunch of money here with no real outcome. We wanted to build a model that yes, we're going to make this large investment, but we want it to live on its own after 5 years. So that's kind of how we built it.
Kelsey, maybe you could speak to a little bit about the sustainability and how the Unite Us tool can help support that sustainability.
Yeah, I think the sustainability is such a key component, because a lot of times you see programs that, are here for 5 years and then they kind of fizzle out. And one thing that I think, again, MoHealthNet does a really good job about is, making it so there's not a lot of red tape. And that to me means that this could be sustained. It's not too complicated or too hard to do in order to sustain past these 5 years. So from like a programmatic and technology perspective, it's something that we always come back to. I think from a technology, there's lots of different things you can put in place and build out to, support processes or things that are required of the model. But we're always kind of reminded of, is that going to create too much of a bottleneck? Is that going to create too much of red tape where people will not adopt and will not use the system? And so I think from a sustainability standpoint, from a technology piece to really support this model and make sure that this can go on long past the 5 years when they're in that shared savings model is to make sure that the technology is easy to use and that it's not overcomplicated or overconfigured.
Yeah, and I'll add one more thing just to clarify kind of how we're looking at this population. We're pulling the Medicaid population for each county that the hospital is located in. So if you have 3,000, 4,000 Medicaid individuals in your county, we're looking at that cost savings as in regardless of where they got their care. So if they are driving past your rural hospital going to Kansas City or St. Louis, if we can still reduce that all-cause hospitalization for that individual, regardless of where it happens, that shared savings goes back to that rural hospital. So we're looking at it on an individual patient level. We're not saying, oh, the cost savings was in Kansas City. No, that cost savings was to that individual. So that rural hospital is going to reap the rewards of keeping them in their community and healthy. And when you think about, a couple $100,000 in savings to Medicaid, that's a simple rounding error to a huge urban hospital, but that's really meaningful dollars to a rural hospital that's struggling. So I just wanted to add that part to the mix there.
Great. Yeah, absolutely. Thank you, Justin. I just want to encourage participants to put questions in the Q&A box. We have some other ones that I want to get through, but want to remind everyone that that's there. Would love for either whoever wants to start on this question of what advice you would give to organizations, maybe both at the state level, like the state agency, but also a hospital or clinic or a community-based organization that feels hesitant or sees barriers to begin this type of work. What advice would you give to those types of organizations?
Yeah, I think the biggest advice I would have is, if you're a state agency wanting to do something like this, or even a hospital wanting to do it on your own, like you have to go out and find who your partners are going to be. Like Kelsey mentioned before, meet them where they are. Don't try to dictate policy from the capital city or something like that. Like go meet them and figure out what their struggles are. Maybe their barrier isn't really a barrier at all. One of the things that I think one of our hospitals highlighted in our last quarterly event was, if ToRCH was a hospital only model, some communities would just be like, no, just turn around and not even entertain participating. Rural individuals and even in urban settings, they have big opinions about their hospital that they use. They could have had a bad experience generations ago and they're never going to change their mind. But, when you surround it with community partners, people that live there, your churches, your food banks, your other entities that are just striving to do this work, but don't know how. And it comes across as this group effort, not just this hospital dominant, you have to do what I say. But when you involve them in the conversation and really take into account what they need and what the one thing is that could get them over the hump. We've had people working on this project that, they were born to do this. They just didn't know how to do it. They weren't given the opportunity in whatever stage of their career they were at. They see the problem every day, but they can't help the person. This gives them the opportunity to actually help people in a way that isn't just go to the doctor and get it fixed. No, you're looking upstream. You're getting them a nutritional meal. Like, you're literally changing their life through a different type of lens. And once you get that buy-in from a community member or a primary care group, it does start to really take off. I guarantee you it'll be hard at times. You're going to have some non-believers, but the proof is kind of in the pudding when you put all of this together and see how it can work in other areas of the country.
Kelsey, anything to add there?
Yes, I feel like I was nodding the whole time to what Justin was saying, but I think just to add on to that is to be creative. I think so often initially when we started to, I think, everyone was a little bit hesitant. They would say, well, this organization would love to be involved, but they can't. But now that the community leadership boards have started to come together, it's like, well, why can't they? Well, they don't have a van, so they can't provide transportation. Well, let's pay for a van. Let's use the ToRCH capacity building dollars to pay for a van. So now, this church organization can provide transportation. Or like, there's another example of, we have all the nutritionists we know what the medically tailored meals should be. We know what the healthy meals should be, but we have nowhere to prepare the meals. So we can't do it. It's like, well, let's figure out how we could do that. How can we create a kitchen on site to make those meals? And so just being creative to help reduce those barriers instead of, looking at it as, I don't have the ability for the technology, or I don't have the manpower or whatnot. This type of model helps you come together, identify those barriers, and then kind of break them down. So that would be my biggest advice.
Yeah, awesome. I'm going to answer a question here that I see in the chat, and then I think maybe we'll have Kelsey and Justin do any closing statements if there's anything more they want to share, and then I have another slide that I want to share out. So wrapping up here in the last 10 minutes, but there's a question in the chat about, it seems like rural hospitals and clinics are hyper-focused on operating costs. I think this isn't associated with the Rural Health Transformation Fund. Recent input sessions have focused on recruitment and retention of medical staff versus technology solutions. How do we change the conversation to something more strategic? I want to note that is definitely something that we're seeing as well. As I'm monitoring this Rural Health Transformation Fund work for across all states. And the hospitals and hospital associations, of which I'm sure there's some attendees here that participate in those, that's obviously a big concern and a big focus of the fund. But we also want to remember that within the approved uses, there's 10 approved uses, and the states have to apply for at least 3 of those approved uses, and that's going to have to come into technology. So I think it's really up to the state to be thinking about and to really be bringing forward those strategic conversations of what are all the approved uses that we're going to apply for? How are we going to make this work in our community? And I think conversations like this one, which talks both about the sustainability and the hospitals and how we can support them, while also bringing in technology advancements, are really a great way to have those strategic discussions. I don't know, Justin or Kelsey, if either one of you have anything you wanted to add there on that question specifically.
Yeah, I think that's a piece that we're really focused on too. I mean, ToRCH provides this kind of ramp up to a mature model. It's going to be hard to address that workforce piece, especially in rural areas of the country. I mean, it's hard to recruit providers to rural America. I mean, what's the incentive? You're far away from all of the social fun things that you can do, but there's also something that I'm from a rural community. I love it. I love being kind of out in the middle of nowhere, and a lot of rural people are like that. So it's tough to create those incentives to draw those individuals in. I don't know that any of us have a perfect answer to it right now, unfortunately.
Absolutely. Well, Kelsey and Justin, I'm going to wrap up here in a minute, but would love to each give you maybe a minute to say anything more you want to say about the work that you're doing on the ToRCH model, or otherwise, something you didn't get to say that you want to make sure that our audience hears. For sake of mixing it up, Kelsey, I'm going to start with you.
Yeah, no, I think this has been a really unique project to be involved in, and I think the reasons why it's unique is just that it is so community led. And I know you've heard us say that multiple times about this, but I think that's kind of important to iterate, is that truly from a technology standpoint, but also from a programmatic standpoint, meeting the communities where they're at has been really key. And I think having that level of key messaging from the top down has also been really critical. So it's been so great to work with MoHealthNet, where they've really set the foundation of this is community led. It always comes back to the community. They need to approve it. They need to have buy-in. Does it work for them? And so I think, as you guys are all, thinking about your own communities, just remembering to really lean on the people that live and breathe it every single day. So I'll pass it over to Justin.
Yeah, I don't know if I have much to add there. You summarized it up perfect there, Kelsey. Always taking into account, what's really happening in that community and what are the things that they really need help with. Every rural community is different. They have a different kind of infrastructure on the things that they can do. What can they do within a year? What can they do within 5 years? You can't just flip a switch and fix it. You have to, build a layered in plan of how to get them, to sustainability and ultimately improve the healthcare of their communities. And ToRCH has been, a passion for us. We operate, it's called the Transformation Office in Missouri Medicaid. There are literally 4 of us in this office, and this is just one of our projects. We have multiple other things that go on outside of ToRCH. So we are very passionate and dedicated. We're not, tasked with keeping the trains running on time. Our director, when he came on here, really wanted to transform how we operate a Medicaid program and create a best-in-class program in the nation. And so he stood up a transformation office to do things like this. And this is probably one of our biggest wins so far, is standing up something like this that we hope to have future cohorts. I mentioned that we have 52 rural hospitals. We would love to have every single one of them involved in ToRCH at some level along the way. So it's not something we're going to quit on. We're dedicated to it. We're committed. We have the full support of our legislature to see this thing continue and to grow. So it's something we're really happy to have going on in Missouri.
Well, thank you so much, Kelsey and Justin. We're really excited about it too. I want to wrap up here. I'm just going to share one more slide here about some of the projects. Beyond just these ToRCH-like projects, some of the projects and suggestions that, as we talk about integrating technology into the use of the Rural Health Transformation Funds, Unitas has tried and has featured many different projects across the country, including other rural areas. We're incredibly proud of our ToRCH work, or really just our support of Missouri HealthNet and the work that they're doing through ToRCH. But some other ideas that we have include projects that leverage Unitas's consumer-facing assistance request forms. Consumer-facing technology is one of the approved uses in the fund. This would allow rural citizens to self-identify their needs and start on proactive prevention and proactively address non-medical needs. Community members could submit these assistance request forms and then be routed to referrals and routed to care through the Unitas Care Coordination team. And then this would all be tracked through the Unitas platform. And the really idea here would be to get people to self-sufficiency. We could also work on harnessing Unitas's insights and advanced analytics to understand at the individual level people's needs, what's going on with them, and then connect them to care. So there's a lot of different ways we can use advanced technology to track improvements over time, to connect people to care, to integrate technology into the rural communities and really work, as Kelsey and Justin have emphasized a lot, work with the communities to support themselves. We are technology, we're here to support, and we think this Rural Health Transformation Fund could be a great way to start that. So in conclusion, I just want to thank everyone once again for coming today. Thank Justin and thank Kelsey, and review kind of what we went over today. I think we worked on understanding the key components of the Rural Health Transformation Fund. Obviously, a lot more to learn, particularly as that application comes out, maybe next week, who knows, mid-September. I think it depends on if you're like a glass half full, glass half empty type person. Is it mid at the beginning of the mid or mid at the end of the mid-September of when this application might come out? We really hope that we can help share some resources from the Unite Us side. Please reach out to us if you want to learn more and if you want to work with us on your rural health transformation application. And we're happy to talk through any of this work. Once again, thank you so much, Kelsey and Justin, and thank you to everyone who attended this. Recording will be shared out and we can share more information as we go. Thank you.